Now we are going to see about follicular carcinoma of thyroid. This follicular carcinoma of thyroid, it is the second most common type of thyroid carcinoma after papillary thyroid carcinoma. It is most common in iodine deficient and endemic areas. Because of the TSH stimulation in this iodine deficient and endemic areas, follicular carcinoma is seen. The second most common in this area is the papillary thyroid carcinoma. It is more common in the second, third and fourth decade of life. It is also more common in females, similar to that of papillary thyroid carcinoma. Papillary thyroid carcinoma is also seen in most commonly in females. All the thyroid carcinoma are more common in females. The important feature of this follicular thyroid carcinoma is it has vascular and capsular invasion. The risk factors of this follicular thyroid carcinoma is any long-standing multinodular goiter, it turns into follicular carcinoma. Long-standing multinodular goiter, long-standing Hashimoto's thyroiditis, they are of increased risk of developing follicular thyroid carcinoma. Also, Cowden syndrome and Gardner syndrome are also associated with follicular thyroid carcinoma. In papillary thyroid carcinoma, we saw radiation exposure as a risk factor, and also thyroglosal cyst. Long-standing thyroglosal cyst is a risk factor of papillary thyroid carcinoma. In follicular thyroid carcinoma, multinodular goiter and Hashimoto's thyroiditis are the risk factors. Next, we are going to see about the clinical features. The clinical features is it presents with the thyroid swelling. Like any other thyroid carcinoma, it presents as a thyroid swelling, a swelling in the front of the neck. It also presents with compressive symptoms. Compressive symptoms is compresses the nearby structures of like trachea, esophagus, recurrent laryngeal nerve. It compresses the trachea to cause dyspnea. It compresses the esophagus and causes dysphagia, difficulty in swallowing. It also causes hoarseness of voice by compressing the recurrent laryngeal nerve. Positive Berry sign is seen. What is Berry sign? Berry sign. Normally the carotid pulsation, where it is seen? It is seen in the medial aspect of the sternocleidomastoid against the superior aspect of the thyroid cartilage, that is against the C6 vertebra. To be more concise, Chisagnus tubercle. Against the Chisagnus tubercle, we can palpate the carotid pulsation. This normal carotid pulsation is not seen. That is called as positive Berry sign. It can be pushed backwards. It cannot be seen in the normal position, or it is not that pulsation is not felt at all. This is positive Berry sign. It is seen in follicular thyroid carcinoma. FNAC investigation. The FNAC, it cannot differentiate between adenoma and carcinoma. So the treatment varies in case of follicular thyroid carcinoma. The spread is most commonly hematogenous spread than the lymph node spread. Hematogenous spread, it spread to the bones. To the bones, it causes pulsatile swelling. That is pulsatile swelling that is seen in the bones. This type of metastasis is also seen in renal cell carcinoma. This is the secondary, that bone metastasis that is seen in case of follicular thyroid carcinoma. They are most commonly seen in the skull region. It is well localized. A localized swelling will be seen. A localized, non-mobile, soft, fluctuant. Because of the colloid content, it is fluctuant in nature and pulsatile. Because of the inner and outer table. This is the inner table. This is the outer table. Both the inner table and outer table is lost. So the brain matter is can communicate with this. So because of this pulsation, the brain pulsation, it is pulsatile. So it is a well localized, non-mobile, soft, fluctuant swelling. Also it is a pulsatile swelling. This is most commonly seen in the skull. So if a patient presents with the thyroid swelling, also with the swelling in the skull, we have to suspect follicular thyroid carcinoma. Next, the management. We will be starting with the hemithyroidectomy. Hemithyroidectomy. What is hemithyroidectomy? The affected lobe along with the isthmus is alone removed. This is hemithyroidectomy. We start with the hemithyroidectomy. On table, we do a frozen section. So pathologist is important here. Pathologist, they will do a frozen section on table. If it comes as, there can be two results. It can come as follicular carcinoma, or else it can come as follicular adenoma. If it comes as follicular carcinoma, we have to treat it like papillary thyroid carcinoma. We have already seen the treatment of papillary thyroid carcinoma. If Follicular thyroid carcinoma is seen in thyroid alone. Like papillary thyroid carcinoma, we are going to do only total thyroidectomy. If this follicular thyroid carcinoma is present in the thyroid, also level 6 node metastasis, that is the Delphi node, is also involved. We are going to do total thyroidectomy along with central lymph node dissection. If follicular thyroid carcinoma is present in the thyroid with level 6 node involvement and other lymph nodes are also involved, then similar to that of papillary thyroid carcinoma, we are going to do total thyroidectomy, central lymph node dissection, and also MRND is also done along with that of the central lymph node dissection. So as we told already, there can be two results. If it is a adenoma, if it comes as the frozen section, if it comes as adenoma, then no surgery is needed. So we'll stop with hemithyroidectomy. Follow-up is also similar to that of papillary thyroid carcinoma. What we did for follow-up, we will be doing radioactive iodine scan to rule out any metastasis, or else if there is any residual disease. If it is present, we will go for ablation. If it is not present, we are going to follow up again with the help of thyroglobulin, follow up ultrasound. We are going to follow up the patient, and this patient we are going to give suppressive dosage of thyroxine. How much you are going to give? Thyroxine 300 microgram we are going to give. This is all about the follicular thyroid carcinoma. Thank you.